Well, hello and welcome to the second annual ENIGMA IPV and Pink Concussions IPV Brain Injury Conference, Breaking Down Barriers and Building Understanding. My name is Katherine Snedaker, and I'm the founder and director of Pink Concussions. Founded in 2012, Pink Concussions was the first nonprofit 501c3 to focus on female brain injury from sports, domestic violence, accidents, and military service. Pink Concussions, in collaboration with Carrie, Esopenko from ENIGMA IPV Working Group, co-developed this conference with immense help from our conference organizing committee. And I mean, it was like every other Wednesday forever. So I really thank everybody for that. Last year, we set out to provide a free and easily accessible venue to provide research and practice-based information to partners on IPV-related brain injury. And last year's conference saw just under 500 people register, with many viewing the recorded sessions online after the conference ended. And I know some people that even signed up this year went back to look at last year's conference. This year, we're so excited on that momentum. We built more than 700 people registering for the conference. Again, this year, we're excited to see a broad representation of registrants globally, as well as represented across many community, advocate, and provider roles. So you can see on that slide the countries represented and the representation of stakeholders. We also heard feedback from last year and sought to include a more diverse representation in topic areas and really expand the knowledge on this important public health concern affecting 1 out of 3 women over the age of 15 globally, and having particularly devastating impact on women of color, women with disabilities, indigenous individuals, gender, and sexual minorities at the highest risk for IPV. And it also included in there women veterans. We have all been using our voices to sound the alarm on the effects of IPV-related head trauma and brain injuries. And even though there are many gaps we need to fill, we are thrilled to see the increase in awareness and research being done on this topic, and the increased focus on providing care for IPV-related brain injuries. Over today, we hope to bring further awareness and understanding of IPV brain injuries, offer hope for the future as we break down global barriers surrounding research and treatment of IPV brain injuries. And I really encourage you, if you like a speaker, write down their email, reach out. These not only are these moments to learn about others researchers, but really connect, see who has someone interested in the field. I have never written somebody and said, will you talk to me, and had them say no. So really, I encourage you all to reach out to each other. We'd like to acknowledge the conference committee who worked tirelessly to develop a program that addressed suggestions from last year's attendees and advance our mission of providing a thorough overview of current research and practice-based information for IP-related brain injury. And as a committee, we'd also like to share a statement on diversity, equity, and inclusion, as well as to acknowledge that our work spans many First Nation, Inuit, and other Indigenous territories, moving forward in a way that promotes anti-racism and inclusivity. We are committed to diversity, equity, inclusion, regardless of race, age, ethnicity, sex, gender, sexual orientation, religious, geographic area, socioeconomic status, disability status, and equity-deserving identities. As the organizing committee, we are cognizant of the bias that exists in clinical practice and research, and thus have endeavored to increase inclusivity by including diverse speakers, a range of understudied topics, and work that incorporates underserved communities. We have worked to increase the accessibility of the conference by providing free virtual recorded environment. We hope this is one small step towards positive change needed in breaking down barriers and building understanding. And the land acknowledgement, we'd like to acknowledge the territory that our work spans many nations, Inuit, Indigenous territories, moving forward in a way that promotes anti-racism, inclusivity, and committed to educating ourselves and understanding the truth of our shared history with Indigenous people. So thank you for that. We also ask any questions on the Q&A box, that we can get your questions and ask the panelists and speakers today. And if they don't answer during their talk, please check back, because sometimes as a speaker, you can't answer the question and then you can answer it afterwards. You can exit and join Zoom as you like. The sessions will be hosted on YouTube in the next few weeks for any sessions you may have missed. Content warning. Additionally, we do have supports in place if needed based on hearing information today. Please direct message the organizers on Zoom and we will respond with information. Also, some other housekeeping. We wanted to give you a heads up that after 500 people, attendees may remain in the waiting room until someone exits the room. But I think yesterday we were under that, so there shouldn't be a problem. However, with the global scope of attendees across multiple time zones, we do not believe, again, we will exceed this limit. In the event that we do, please know we'll do our best to make recordings available as soon as possible, and we encourage you to join a later time as we anticipate attendance will fluctuate greatly throughout the day as we go through different time zones. With that, let's get started on day 2. And I'm very, very excited to announce the keynote researcher today. And I do want to let you know that Carrie did not vote on this. We voted on this as a committee and decided that Carrie really would represent who we wanted to today. Dr. Carrie Esopenko is an associate professor in brain injury research at the Icahn School of Medicine and Mount Sinai Hospital in New York. She also holds adjunct faculty appointments at Traumatic Brain Injury and Concussion Center at University of Utah, as well as the Department of Family Medicine and Community Health at Rutgers Robert Wood Johnson Medical School. She's the principal investigator of the National Institute of Neurology Disorders and Stroke R1-funded multi-state study examining the psychological, cognitive, and neurosignatures of intimate partner violence-related head trauma. And she is a co-investigator on the Department of Defense-funded randomized controls trial seeking to address emotional dysregulation, PTSD symptoms in female veterans with brain injury as a result of intimate partner violence and military sexual trauma. She is the lead investigator of the ENIGMA Intimate Partner Violence Working Group seeking to increase IPV brain injury research collaboration worldwide and co-leads ENIGMA Global Knowledge Network. Let me try that again. Co-leads the ENIGMA Global Knowledge Exchange Network, which works to provide education and training supports to service providers and advocates working for IPV-related brain injury. Her research focuses on an understanding of the effects of neurotrauma and mental health conditions across populations and identifying methods for injury prevention and patient-specific and community-based intervention strategies. She was recently awarded the 2024 National Neurotrauma Society's Rosalind Franklin Award, in acknowledging her impactful scientific contributions to neurotrauma research and work in improving advocacy and education for intimate partner violence-related brain injury. And the title of her talk is IPV and Brain Injury and the Current State of the Science. And I'm also lucky enough to call her a friend. So with that, I pass it over on time to Carrie.
Thank you so much. And thank you for that wonderful introduction. I am going to share my slides. And everybody sees the right screen. Yeah, perfect. All right, so thank you. I'm so excited to be here today. Here are my disclosures, although they will not impact anything that I'm going to be talking to you all about today. And again, I just really want to provide a content warning. Given the prevalence of IPV, I recognize that this content is likely triggering for some. So please take care of yourself during the talks, my talk today and the rest of the talks. If you do need support again after this presentation, reach out to the organizers and we'll make sure to help, as well as feel free to mute us or rejoin later if you'd like. So I realized that I gave myself a pretty daunting title to go with, the state of the science, and especially as we're watching all the incredible research that's being done, and especially from our trainees. I'm just blown away by all the trainee work. So today I'm going to try and talk a little bit about what we know or what we think we know, and then go through some expanding and emerging areas of research, and specifically looking at screening and identification, biomarkers for IPV-related brain injury, and the long-term effects of IPV-related brain injury. And our team, a group of us, came together recently and put together a paper that really highlights these gaps and how we want to try and close them. So if any of the stuff that we're talking about today you want to see more detail of, I urge you to go take a look at this. And then we'll end with talking about some collaborative research building that we're doing through the ENIGMA working group, and a call to action to have more people join us. So we know that the global burden of IPV is profound. It impacts all communities, all walks of life. No one is immune to IPV. And hopefully through the work that we're all doing and all of us coming together, we can really start closing that gap and helping with specifically the brain injuries that people are experiencing as an outcome of IPV. And since physical and sexual IPV often include injuries to the face and head, as well as suffocation, strangulation, or other forms of impeded breathing, IPV puts people at an extremely high risk of experiencing brain injury. And so when we look at the prevalence of IPV, there's been a number of systematic reviews that demonstrate that anywhere between 27 and 100% of women in these studies report experiencing IPV-related head and facial trauma. And I do want to put a bit of a caveat on that 100% number, that the studies often are recruiting people that have experienced injuries, and hence the 100%. But even at that 27%, that's a devastatingly high prevalence. And when we do talk to women in these studies, more than 50% of them often report multiple impacts with exposure to head trauma, and many are reporting so many injuries that they can't even count. And it's been estimated that approximately 23 million women are living with IPV-related head trauma in the United States specifically. So we know that number is profoundly larger when we look globally. And what's limited here is that many studies also do not account for what's happening under the age of 18 or the problematically high rates of teen dating violence. And recent work from University of Calgary groups and the University of British Columbia showed that in a sample of Canadian high school students, 24.8% reported teen dating violence. And what they saw was that past teen dating violence victimization was really strongly associated with a higher odds of past year concussion, with the odds being even stronger for non-sport related concussions. So likely those concussions due to dating violence. And when we look at exposure to IPV, even in the absence of head trauma, we know that there are cognitive problems. So we see things like impaired reaction time, response inhibition, working memory, and executive dysfunction. We also see lots of psychological complaints. So things like depression, anxiety, substance use disorder, suicidal ideation, and PTSD. There are also physical components. So chronic pain, urological, cardiovascular, and gynecological conditions, as well as neurological changes. So things like reduced cortical thickness, white matter integrity, and altered functional connectivity. And thanks to our early pioneers who really sounded the alarm bells about the intersection between IPV exposure and brain injury, we've known for around 20 years, based both on clinical experiences as well as research, that IPV related brain injury impacts multiple functional domains. So we know that there's physical symptoms like headaches, chronic fatigue, nausea, dizziness, and blurred vision. There's cognitive complaints, issues with judgment, concentration, multitasking, recall, and organization. There's lots of sleep complaints. We have people talking about sleeping more or less, sleeping at odd times or having troubles falling asleep and really not feeling rested, as well as a lot of psychological components, so depression, anxiety, suicidality, impulsivity, and emotional liability. And I urge you to take a look at the ABI toolkit. There's a lot of information here that's helpful for both survivors and clinicians doing work in this area, as well as us researchers wanting to make sure that our work is clinically valid. So as a group, we've really been trying to push that IPV-related brain injury is a distinct phenotype of brain injury that looks different than what we see in other brain injury populations. And so if we think about the mechanisms of brain injury, we can have somebody who is kicked, hit, slammed into something, and this can cause focal injuries to the brain. We also have people that are shaken violently, shoved, pushed, and this can have diffuse injury to the brain, so impacting the white matter tracts within the brain. But we also know that many of these mechanisms are happening at the same time. So we're seeing both diffuse and focal injuries occurring. And then we have non-fatal strangulation, suffocations, or other forms of impeded breathing. And this can lead to anoxic, hypoxic, or hypoxic ischemic brain injury. So yet another form of injury. And what we also know is that these injuries tend to occur together within a same abusive injury episode. So you have an individual that is experiencing focal, diffuse, and potentially anoxic, hypoxic, or hypoxic ischemic injuries. But what we're also seeing is that these injuries are repetitive over time. So these injuries can be happening multiple times within the same episode of abuse, or they can be happening in these episodes over time for months and years. So really causing long-term situations for these individuals that are experiencing these abusive relationships. So there's now data coming out that does support this notion that repetitive exposure to brain injury occurs as a result of intimate partner violence. So our team has been conducting a study for the past 4.5 years, recruiting women who have experienced severe physical violence as a result of intimate partner violence. And one thing I do want to note is we've been recruiting for a number of years now. And the interesting thing here is that when you're recruiting for people that have experienced severe physical violence, we're actually having a difficult time finding people that haven't had exposure to head trauma. But in this group, we found in our sample of 72 women, 69 reported at least one injury episode that involved intimate partner violence related head trauma. And within that, around 50% reported exposure to repetitive injuries. And then across the sample, we found that across our 69 individuals who reported IPV head trauma, there were 240 individual intimate partner violence related head trauma episodes. So those 69 individuals reported 240 episodes. And because we did a semi-structured interview with these individuals and allowed them to tell us all the different mechanisms of injury that they were exposed to, we could have a rundown of the different types and frequency of mechanisms of injury that they reported both within a injury episode or an abusive episode and across different abusive episodes. And what we found was that the most frequent single mechanism of injury that they were exposed to was from blunt force trauma, non-fatal strangulation or being choked, or being shoved or falling. And when we looked at mixed episodes, so where multiple mechanisms of injury were happening within a single abusive episode, what we found was that the most reported was blunt force trauma with other, and other just refers to a mechanism that's not already classified as blunt force or strangulation, etc. The second most frequent was blunt force trauma and strangulation together. And the third was blunt force trauma and a shove or a fall. And as you can see from this figure, you can see from the dots and lines that many individuals are reporting, multiple different mechanisms of injury. And approximately 6% included more than 3 different mechanisms of injury happening within that abusive episode. And this is consistent with past work from Jessie Meyer, who had a community sample of women who had been exposed to intimate partner violence. And what they found is that there was, these individuals were exposed to many years of abusive relationships. So within their sample, the length of time that an individual reported being in an abusive episode was a mean of 33 months with a median of 44 months. And when you look at the range of different episodes of head trauma that they're exposed to, their participants were reporting a range of 0 to more than 1,000 subconcussive hits. And from 0 to 183 mild TBIs were reported. And then when you look in those hypoxic events or mild hypoxic ischemic brain injuries, they found was that, the self-reported exposure to hypoxic brain injuries sustained was anywhere between 0 to 39. So you can see that these individuals are exposed to a number of different mechanisms of injury within an abusive episode and across abusive episodes, and that can last for a long period of time. So they're exposed to those over a period from months to more than a year. In some cases, years. And recent work from Justin Carr's group found in a sample of women that were seeking protective orders who had exposure to intimate partner violence, head trauma. What they found is that approximately 27% of their sample reported more than 4 head injuries. And what they found was that those individuals that reported a greater number of lifetime head injuries were exposed to more severe physical and sexual intimate partner violence, and that the greater lifetime exposure to head injuries was associated with greater cognitive, physical, emotional, and total symptom severity. So this is really demonstrating that not only are we seeing these exposures, but these exposures are having a significant impact on the individual's quality of life. Also impacting and causing IPV to be a distinct brain injury phenotype is the specific effects of non-fatal strangulation. So again, from Jessie Meyer's sample that she recently reported on, approximately half of her sample reported mechanisms that are conducive to hypoxic brain injury. And within that, they found that these individuals reported experiencing between 0 and 408 hypoxic events or probable hypoxic events, with around 39 of them resulting in hypoxic brain injury. And I just really want to comment on here for the brain injury folks that we always want to try and figure out if it's a brain injury or not. But 408 hypoxic events means that person experienced at least 408 traumatic experiences. And so we have to be coupling and understanding that these events are probably really coupled with a traumatic experience as well that's on top of that exposure to injury. And Eve's group found that exposure to strangulation-related alterations in consciousness had distinct outcomes compared to people with other forms of IPV-related brain injury, such as further decreases in long-term memory, as well as increased PTSD and depression symptomology, again, compared to other people that are experiencing IPV-related brain injury. And a recent work from the UBC and Mass General groups that combined data from Canada, United States, Spain, and Colombia found that in their sample of this combined data, almost 40% had reported experiencing both strangulation associated alterations in consciousness and other forms of IPV-TBI. And again, the women that reported exposure to strangulation showed increased PTSD and depression symptom severity, again, above what you're seeing in women with IPV-related, other forms of IPV-related brain injury. So really, again, driving home this idea that NFS is causing specific and distinct impacts on the quality of life. And I urge you all to check out the recording of Hannah Vardo's keynote yesterday and to tune in to Drs. Patch and Campbell's presentation specifically about NFS today at 4:15. Another component to consider with IPV-related brain injury being its own distinct phenotype is co-occurring psychological trauma and the potential for PTSD. So there's data showing in a sample of US women veterans that veterans with IPV-related TBI and current symptoms are more than 5.9 times more likely to have probable PTSD. And IPV-TBI with current symptoms, individuals with IPV-TBI and current symptoms are more likely to meet criteria for DSM-5 PTSD symptom clusters. And work from Justin Carr's group showing in a survey out to women with IPV-related brain injury found that those with IPV-related brain injury showed higher PTSD scores, and again, on those clusters of symptoms. And recent work from our group, we found that a higher proportion of our sample with IPV head trauma, but also individuals who had experienced physical IPV, met the clinical cutoff for PTSD. So we really need to be considering comorbid PTSD when we're understanding how brain injury is impacting our survivors. And I think all of us would do good or would probably expand our research if we started chatting more with our scientists and researchers doing work with military and veterans, or military service members and veterans, because comorbid PTSD is also really a profound issue in that sample. And so being able to combine what we've been doing to have a better understanding, I think would really move this forward. And we also need to consider that individuals with exposure to IPV have greater exposure to cumulative trauma. So this increases both the risk for IPV-related brain injury, but also mental health symptoms. So we're seeing that women with IPV-related brain injury show higher numbers of adverse childhood experiences, as well as exposure to community violence. And Dr. D'Souza's group found that ACEs and community violence predicted worse PTSD symptoms. And recent work again from Dr. Valera found that in their sample of women, a really high proportion, almost all of them, had reported exposure to childhood trauma. And childhood trauma on its own was associated with worse somatic and neurobehavioral symptoms. And we have a sample of military, female military veterans who were not being seen for brain injury, but were being seen for PTSD assessments. And we found in that sample that half of them reported exposure to military sexual trauma and IPV. And within the group that reported both exposure to MST and IPV, 80% reported experiencing childhood physical abuse, and almost 70% reported experiencing childhood sexual abuse. And what we found is that greater cumulative trauma was associated with worse depression and PTSD symptoms. And so these early and ongoing exposures to trauma are likely also impacting what we're seeing in women that have experienced IPV-related brain injury. And it's something that I think we really need to be considering as we move forward. And I urge you to check out the recordings from Rachel Ramirez and Dr. Wendelin Hume's presentations from yesterday when they're finally posted in a couple weeks, we hope. So now talking about screening and identification of intimate partner violence related brain injury. This is, something that has been an ongoing conversation for a while, is how do we adequately screen and identify these injuries? And particularly when we're having situations where it's, again, very distinct and that there's, no witnesses. It's hard to recall what happened because it's typically also coupled with other events that are happening. And so we've been trying to push this idea of improving screening and identification. And through the ENIGMA consortium, we had in 2021, so this is already quite dated, we had come together as a group and tried to develop measures to address IPV and family-related violence, as well as TBI exposure. And our goal with doing this wasn't to say you must use these measures and all these measures, but it was that if you're going to try and look at this, maybe try and use some of these measures, because for one, they're common data elements, and we know that we can combine them across samples. But recent work from, again, a collaboration between Monash University and University of British Columbia did a systematic review, or not systematic review, a review on the current state of the screening tools for IPV-related brain injury specifically. And they highlighted the tools that have been developed and used to specifically assess IPV-related brain injury. And I urge you all, especially if you're in the realm of trying to do this clinically or from the research component, to take a look at this paper. But what they did is they went through each of the assessment tools that is being used both clinically and across the research literature. And they described each of the tools, how long the tools were, what the tools were used to assess, and then their past usage. So whether it's been used in a research or a community situation or a clinical situation. And then they went a step further and also provide the advantages and disadvantages of each screening and assessment tool. And so they show which each tool had, why it was developed, and the advantages of how it was developed. So whether or not it fulfills the ACRM or the American College of Rehabilitation Medicine definition of mild TBI diagnostics. They talk about whether or not it has been validated or if it's partially validated, and whether or not it specifically asks for IPV-related brain injury prompts. And so the reason I'm really promoting this is that you can go to this paper to take a look at the description and the advantages and disadvantages and see how it will accurately work for your population and what you're doing. And so I want to take a moment to show why it's so important for doing screenings with tools that have prompts. So Dr. Dom's O'Connor has been doing a long-term study on the effects of, or the late effects of brain injury, and they used the the brain injury screening questionnaire, which was developed to elicit in-depth screening of brain injury in general across 19 different injury situations, with additional modules for sports and military-related injuries. And they found the need to develop a module that was specific for IPV-related brain injury. And so they developed a module based on the original BISC through an iterative process that included input from survivors and advocates. And they had this unique opportunity to compare responses on the standard BISC of TBI that includes 2 cues to assess brain injury from violence or assault, compared to the IPV module, or the BISC with the IPV module, which includes specific probes for IPV-related head trauma. And when they did this, they found that 34% of females and 5% of males reported IPV-related head injuries, or NSS. But when the BISC IPV module was used, the self-reported violent head trauma doubled. So they found that 9% who completed only the BISC, so where there's only 2 questions probing about violent TBI, while when the BISC IPV module was completed before the standard BISC, 19% reported exposure to violent brain injury or violence-related brain injury. And so what this has really demonstrated is that specific IPV-related recall cues may be necessary to really comprehensively ascertain how injuries happened and what happened. And I urge you to check out the recordings from Dr. Carolina Botteri and Dr. Kathy Cho's presentations from yesterday. They went really in depth on different screening in different populations. So when we keep talking about screening and identification of IPV-related brain injury, I want to take a moment to talk about sex differences. So we often say that that women are experiencing more severe and more chronic outcomes due to exposure to IPV-related brain injury. But when you look into the literature, there's actually not a lot of information on IPV-related brain injury, specifically within males. And so we had a unique opportunity to work with Dr. Amy Marshall, who's at Virginia Tech, and my postdoctoral fellow, Dr. Divya Jain, to look at this specific question through the CIRCLE study. So the CIRCLE study stands for the Children, Intimate Relationships, Conflictual Life Events, and Stress Study. And it was designed to better help understand how stressful life experiences and current stress impact men's and women's experience of family conflict. So this was not a study specifically on IPV, but rather on looking at stress within relationships. And to be part of this study, the individuals had to have cohabitated for at least 3 nights per week with an intimate partner and be the parent or the partner of a parent of a child aged 3 to 5. And another big component of this is that both partners had to be willing to participate in this study. And so Amy's been working on our other IPV study, and when she started this was like, I should add in some information about IPV. And so she included the traumatic life events, a modified version of the Ohio, which I will tell you about, and measures of PTSD and depression. And our goal was to try and understand unique associations between IPV-related head trauma in women and men, and how that relates to PTSD and depression in community-based samples. And so for the physical IPV, it was determined using the TLEQ responses of, have you ever been, slapped, punched, kicked, choked, or otherwise physically hurt by your spouse or partner? And then for the modified Ohio TBI survey, we modified it to have specific questions about strangulation, but then also asked a follow-up question was, who caused this injury? So was it caused by a parent, caregiver, intimate partner, someone else, or not a person? And we had 417 participants in this. Around half the sample had exposure to IPV. And so when we look at the self-reported mechanisms of injury, specifically non-violent related mechanisms, we see higher exposure to brain injury in males for sports and for being close by when an explosion happens, which is what's pretty standard in the literature. But then when we looked at exposure to violent related injuries, we do see sex differences in responses to whether or not you've been strangled, choked, or otherwise had your breathing restricted. and then a period with multiple repeated impacts to your head from a parent, caregiver, or intimate partner. The thing that was a little bit shocking to me, not gonna lie, is the percentage of males that actually reported exposure to being strangled, choked, or otherwise having breathing restricted. I didn't expect to see, 14% there. So when we do look at the sex differences, though, we see that women are reporting higher exposures to violence-related head trauma. But when we dive deeper into this and we ask who did it, this is when the differences really came out. So when we look specifically at intimate partner, across the board, a higher proportion of women are saying that this was due to an intimate partner, whereas males are saying this was due to a parent or someone else. And so we can say from this, at least in this sample, that women are experiencing higher rates of violence-related injury at the hands of an intimate or dating partner. And we also learned something else from this study, is that your comparison group really matters. And this is something, we've been discussing as groups for a long time, is like, who do we compare to when we're looking at the responses from IPV-related brain injury? Because we have to be accounting for like the past exposures to physical trauma. And when we looked at PTSD symptom severity and depression symptom severity in this group, we found that, IPV-related head trauma had the highest rates of exposure to PTSD symptom severity and depression symptom severity. But what we also found is that exposure to physical IPV also is associated with higher PTSD symptom severity and depression symptom severity. So we do need to be really trying to understand and highlight the differences between IPV head trauma and exposure to physical IPV when we're looking at mental health outcomes. So now I'm going to talk about biomarkers for IPV. So we talked about screening and identifying it from self-report measures, but what about biomarkers for IPV? So why are objective biomarkers so important? Well, they allow us to provide more accurate identification and diagnosis of injuries. And this is particularly important when there are no witnesses to injury or the question of what types of injury mechanisms and severity of injury occurred. And it helps us to understand the pathophysiology of injuries, so we can determine the specific effects different mechanisms of injury have on the brain and relate that to functional outcomes. And it also allows us to better prognosticate the injury, so determine the course for recovery, rehabilitation needs, and potential long-term effects. And it will also help us identify those with an undiagnosed or remote history of injury, which can then be used to inform current symptoms and aid in determining treatment strategies. And so in the TBI world in general, there's been a lot of work trying to identify objective biomarkers. And these include the use of neuroimaging, fluid-based biomarkers, and physiological biomarkers. And so when we talk about the potential for developing fluid-based biomarkers for IPV brain injury, and specifically for hypoxic ischemic brain injury that's an outcome of NFS, currently there hasn't been any data on this within the IPV-related brain injury community, but we have been looking to individuals that have had cardiovascular events to understand this. And there was a recent review or systematic review and meta-analysis that came out that looked at over 10,000 cases of cardiac arrest to try and identify biomarkers of neurologic function associated with ischemic brain injury. And they looked at, and they searched for those key brain injury biomarkers that have been identified in the literature and in our populations. And what they found when they looked at the biomarkers that were assessed 48 hours after return to spontaneous circulation, so when blood flow had returned to the brain, what they found was that NFL followed by tau just demonstrated the highest predictive value for unfavorable neurological outcomes. So there's no studies that have addressed this specifically in IPV-related or hypoxic ischemic brain injury, but these do suggest that NFL and tau might be one of the probes that we should be looking specifically for. And this was followed up by work from Sandy Schultz's group. And they provided us just recently one of the first studies examining blood biomarkers in IPV brain injury symptoms in patients presenting to an emergency department. And what they found was that patients with IPV brain injury showed elevated NFL and worse brain injury symptoms relative to healthy controls, orthopedic trauma controls, and other non-IPV brain injury groups. So we are starting to see that that these blood-based biomarkers do or will be making an impact in this field pretty quickly. And I can say, based on the work that Cheryl Wellington and Sandy Schultz and Paul Van Donkler are doing out in UBC, that hopefully we'll see some really interesting movement on this soon. And I urge you to tune into Dr. Schultz's presentation today at 3:30, where I'm sure he'll talk about this in way more depth. We also have neuroimaging biomarkers. And so we look at structural MRI, and specifically there's been studies, again, by Eve Valera's group, looking at changes in the white matter tracts within the brain, and specifically using diffusion tensor imaging. And so diffusion tensor imaging basically allows us to measure water molecules in the brain. And water, when it's not in a structure, molecules move all around. But when it's in a structure, it's highly anisotropic, and so it moves throughout a structure in the course of a tube, so like an axon. When there's damage to that, we see changes in those white matter tracts, and we can measure that using diffusion tensor imaging. And Eve's group found that decreases in the structural integrity in some of these tracts within the brain are associated with the brain injury severity score. So using the BISA, which accounts for recency and frequency severity of brain injuries, she found that the higher that BISA score was, the lower those tracts were. There's also been recent work showing changes in overall cortical thickness. So cortical thickness allows us to measure basically the thickness of the cortex, so between the gray matter and white matter. And in a sample of survivors of intimate partner violence, they found that there were changes in cortical thickness between individuals who had experienced a traumatic brain injury versus not. But what they also were able to do was look at IPV-related TBI specifically compared to other types of TBI. And what they found was that there was specifically decreases in cortical thickness in the paracentral gyrus in women that had experienced IPV-related TBI compared to other types of TBI. There's also a paper from Julia Dougherty's group that compared brain volume, surface area, and cortical thickness in females with and without IPV exposure. And what they found for volume is that survivors showed greater number of areas with reduced volume compared to people who were not exposed to IPV. And similarly, with regards to surface area, they found a few that the survivors showed more on some areas, but not others. And then for cortical thickness, it was about half. There was differences between our survivors and non-survivors. And, you know, when you think about imaging, we always think that things are going to be reduced because we think reduced is bad. So it's confusing to think about things being higher in imaging. But when you look deeper into this sample, what they found was that specific changes in brain volume were also associated with TBI and strangulation. So they found in these regions that were showing differences between survivors and individuals without exposure, that exposure to TBI was associated with reductions in brain volume and surface area and thickness. And same thing with strangulation, that there's some reductions in cortical thickness. But what they also found was that there were associations between increased thickness, volume, and surface area and exposure to ACEs, past abuse exposure, and PTSD. So what this is really telling us is that we may see changes between survivors and non-survivors, but we really need to be accounting for TBI and childhood trauma and mental health outcomes, because these are impacting the volumetrics. There's also studies that have looked at functional MRI and specifically changes in resting state functional connectivity. And resting state functional connectivity basically allows us to look at how the brain is operating at rest, and specifically how different areas are talking to each other. And we, for years, have been looking at resting state functional connectivity of different networks. And one of the key networks we look at is the default mode network. And the default mode network includes mainly regions within the middle of the brain and into the temporal lobes. And we know a lot about this network because it's the network that is active when you're just daydreaming and not even really concentrating on anything. And we have, as a group, as a science, have spent a lot of time looking at how default mode changes based on aging, Alzheimer's disease, brain injury. And so this is one of the reasons we always look at it first, is because we know the most about it. And what Eve Valera's group found is that reductions in functional connectivity of this network is associated with increased brain injury score. So again, when you have a higher brain injury score, so more severe, frequent, and recent, that it's associated with reductions in functional connectivity of some networks or some of the regions within the default mode. And that's similar to what we see in the TBI, aging, and Alzheimer's literature. Other work from the same study that was looking at the cortical thickness also found differences in functional connectivity between women with IPV head trauma, or women with traumatic brain injury versus not, who had experienced IPV. And what they found was that TBI was actually associated with increased connectivity or hyperconnectivity, which is something that we also do see after brain injury, because you need to talk more between the brain injuries as you're recovering, but also showed decreases in connectivity in the frontal lobe. But what they also found, which again is coming back to we need to be accounting for those other things, they found that the differences in connectivity, specifically within the right superior parietal cortices, was related to PTSD. And so higher PTSD severity was actually associated with reduced connectivity, regardless of TBI exposure, whereas that the increases in the frontal lobe, or the decreases in the frontal lobe, were related to age. So now I'm going to switch gears a bit and talk about the long-term effects of IPV-related brain injury. And so there's always questions in survivors, in our clinical individuals, or our practice-based individuals, and our advocates, and what's going to happen long-term. Does IPV look like what we see in football players? And how do we dive into that? What do we tell people that they're going to experience long-term? And the true answer to that is we're trying to figure that out. But there has been some studies that have been specifically looking at neuropathology long-term. And the question that we always get is, is IPV-related brain injury going to be a model like football for exposure to developing chronic traumatic encephalopathy? And so there have been some studies, case studies, looking at neurodegenerative diseases in individuals with IPV brain injury. And I'm going to highlight a couple of them. So there was a case series of a 29-year-old female with domestic violence history who died due to a domestic violence incident. And when you look at the medical reports, she had years of exposure to repetitive head impacts. She had evidence of head lacerations and scarring, as well as cauliflower ears. She also had neck injuries, including a fractured bone, and no clinical history to suggest behavioral impairments or memory impairment. And she had participated in sports in her past. And upon autopsy, the histochemical or the immunohistochemical staining revealed evidence of chronic traumatic encephalopathy pathology. And so they did see phospho-tau immunoreactivity within neurons, glial cells, and neurites in areas in the depths of the sulcus, as well as near the cortical gyrus in the right and left temporal lobes, as you can see here. But they did also find amyloid Wow, I'm going to take a sip of water. Amyloid precursor protein in the splenium and internal capsules. And so they diagnosed this brain with having CT type pathology that was best classified as stage 1. So that's the lowest stage in the CT staging. There's stages 1 through 4, dependent on how much tau is within the brain and the spread of it. And so this individual had stage 1 CT based on the tau in the temporal lobes. Another case study examined 2 individuals, 2 cases, and these were women with complex health issues and longstanding IPV-related exposure to IPV-related head injuries. Both had multiple facial and scalp scars and recent scalp lacerations, but no history or evidence of strangulation-related injuries. And for case 1, they found evidence of diffuse traumatic axonal injury and evidence of stage 2 CTE with the 4 perivascular foci of p-tau in the depths of the sulcus. But they also found other pathologies like RTEG and low-level Alzheimer's disease neuropathologic changes. And in case 2, they found that it was overall the brain was macroscopically unremarkable, but they did find evidence of stage 1 CT with 1 neuronal p-tau foci in the left dorsolateral prefrontal cortex or frontal cortex, as well as 4 sulcal regions with low-level p-tau. But here you can see on this chart that these individuals both had, multiple neuropathologies that were shown on these stainings. So recent work, again, from Dr. Doms O'Connor, tried to really expand on this and give us more information on whether or not, individuals with exposure to IPV brain injury are at risk for CTE. And so they had 2 case series. The first series included 14 IPV cases that were obtained through the New York City office chief medical examiner. And this case series had a very complex exposure and medical history. And the series 2 included 70 archival IPV cases that were accrued from multiple institutions. And they also had complex histories of depression, epilepsy, and alcohol use disorder. And so when they looked at the brains after autopsy, in series 1, they did see that TBI was, detected grossly or macroscopically. 6 of the cases had cardiovascular disease. 1 had evidence of Alzheimer's disease, but none had evidence of CTE pathology. For series 2, many of them had appreciable old or recent traumas. Few had minor age-related proteinopathies, but again, none met the criteria for CTE. So these cases, they suggest old and recent traumatic axonal and vascular injury, which may reflect both exposure to mechanical impact or torsional injury, as well as hypoxic ischemic factors, potentially as a result of exposure to non-fatal strangulation. So this is showing that we're still trying to figure out that question of the long-term effects, that we do have some studies showing that there is evidence of CTE, others that are showing that there isn't. And this is similar to our football players. Not everybody goes on to develop, long-term issues after playing or after having lots of exposure to repetitive head impacts. And I think the big take home that came from this work so far is that, and I'm going to read it quote for quote here, these observations reinforce a need to consider broad, comorbid, and neuropathological substrates contributing to brain health outcomes in the context of IPV, which means we need to think about other things that could be going on because some of these are potentially modifiable. So we need to be identifying brain injury early and stepping in early to stop the progression that could potentially be happening long-term. And I urge you to also check out a recording of Natalie Jenkins' trainee data blitz from yesterday when it's posted and her data is published. We will let you know when that happens. But again, she gave a great talk on what happens sort of between middle adult age to later age and how people are performing on brain and behavioral outcomes. So now, I've tried to tell you a lot about the work that's being done and the gaps and these emerging gaps and what we're hoping to close as we move forward. And so now I want to talk to you about the large research collaborations that we have developed through the Enhancing Neuroimaging Genetics through Meta-Analysis Consortium, and specifically the Intimate Partner Violence Working Group. So ENIGMA, which you've probably heard the name thrown around a lot because it's part in the title of this conference, but ENIGMA is a giant research consortium that was developed by Paul Thompson, and it's a collaborative network trying to share data, ideas, and methods and resources. It's a consortium that provides frameworks for analyzing data and combining large swaths of data from across different countries and global partners. And currently it includes around 2,000 scientists from 43 countries with 50 different working groups. As you can see from all the colors on these, or the dots on these on this figure, but 50 working groups that are dedicated to a study of neuroimaging, genetics, and brain health. And so within ENIGMA, there's a specific group on brain injury, and it's led by Doctors Emily Dennis, Lisa Wild, and David Tate. And they really are our leading force here, and have developed further groups within brain injury, because as we know, everything, we have all of us working in different fields. And so they've developed, 8 working groups looking at different components of brain injury, from military brain injury, sports-related injury, and of course, we have a group dedicated to intimate partner violence. And the ENIGMA IPV working group was developed in 2018 when the overall brain injury working group, identified a need for IPV-related neurotrauma, and asked for us to develop and start this group. And since we did, the group currently consists of over 70 members globally. And this collaboration includes researchers, clinicians, and community stakeholders. We try to make a group where people working in research are coming in and providing their influence, but also we want to really make sure to have clinicians and community partners that are in this group, because we really can't do research without our clinicians and our community partners. We have to make sure that what we're doing is actually going to have benefit to the people that you are seeing in your clinics, the people that you are trying to provide supports to. So we have a big open door policy of including the advocates in the room with us. And so the aims of the group, we initially, as I showed you in that paper, suggested specific cognitive, psychological, neuroimaging, and genetic measures to include in studies. And again, the reason that we have tried to make suggestions for inclusion of different measures is so that when we come together, we know that we can combine them together. We know that those measures will assess specific domains of function, and we know that those are the ones that we can bring together and combine. We also, as a group, provide analysis pipelines. So again, as you saw, there's 50 working groups, and everybody has developed different imaging pipelines or harmonization of behavioral data like PTSD measures. And so we provide access to those pipelines so that you can, either analyze the data in similar ways or combine your data. We do invite investigators to contribute data so that we can work on facilitating meta or big data analysis across the world, really. And then we also make sure that we provide, recommendations. Again, we have our care providers, our community partners, our clinicians in the room, so we can really try and help provide recommendations for participant safety within studies. We want to make sure that every experience that a person has coming to participate in a study is positive and it is rewarding. We also include info on the importance of accounting for social determinants of health, so accounting for things like socioeconomic status, as well as knowledge translation. And we recently added a component to this of capacity building for frontline service providers working with individuals with intimate partner violence related brain injury. And I will say, we do have a current call out for data for our first huge meta-analysis that we will be doing in the new year. And so if you're working in this, if you're an advocate or a community partner that's been collecting data and you want to join this, please reach out to me. If you're a researcher, please reach out to me, but we are combining and we have an open door policy. So if you participate either by, contributing data or by helping with the papers, you will be included as an author. We are very inclusive and try to make sure that everybody gets to play in the playground. And so we've published some papers on the measures again, and we recently just published a paper really describing important considerations, kind of lessons that we've all learned from doing research in this field, to try and help others do this work. And sometimes it can be really daunting to want to get into IPV related brain injury work. But we need more of you, and we need more to get rid of some silos, and all of us start working together to really expand and move this field forward. And so we're trying to help provide recommendations for doing that, again, safely. And we are, making sure that everything that we are learning here, that we are trying to translate it. There's this like 17-year implementation gap of how long it takes for our research findings to get into the hands of our providers, our advocates, and our clinicians. And we want to try and close that. So we're doing that through this, hosting conferences with Pink Concussions. We're trying to share widespread vetting of resources. And we're also trying to develop easily accessible information for our survivors. One of the things that we did was we developed a video on how to navigate the legal system as a way to give back to our survivors who have given us so much time by participating in our research. And again, we developed this, the Global Knowledge Exchange Network. And so for any of the care providers or community advocates on the call, this is for you. We developed this for you. It is to try and help provide education and information that you've been requesting for so long. We are trying to do this through the Knowledge Exchange Network. Please scan this link if you have info, but basically it's fireside chats where you get to come and talk about specific things that you're having trouble with in clinic, and we give a specific topic for the discussion. And then what we do, we have some researchers on the call who identify the big gaps that you've told us that you're seeing or that are prohibiting you from being able to provide the best experience. And then 2 months later, we come back and provide an education session. So we go out into the community, we find the expert in that gap, we bring them back in, and we get them to provide you with an education session. So please, if you're interested, that's specifically for you. And so now to wrap this all up, the scope of this problem is significant, yet it's extremely understudied to date, and more funding is drastically needed. We really, really need to get more work funded, and we need people coming to the table with that. We know that IPV brain injury likely represents a distinct brain injury phenotype that uniquely impacts cognitive, psychological, and neurological health outcomes. And we need to be screening for and characterizing the different mechanisms of IPV-related head trauma, particularly in our underrepresented and underserved populations. And again, I urge you to check out the presentation from Dr. Wendelin Hume yesterday, and to check out today's presentations from Dr. Martina Onto-Okra and Cynthia Amadeo. Objective biomarkers, they have the promise of providing better identification and differentiation of the underlying causes of symptoms, and also allowing us to differentiate what the symptoms are being caused by, whether it's an injury, whether it's psychological trauma and or PTSD, so that we can better target management strategies. And substantially more research is needed on the effects of exposure to intimate partner violence, brain injury, the influence of mental and physical health conditions, and the social and biological determinants on long-term brain health. So we need more work trying to understand what's happening long-term. And I'm going to conclude this saying that we will all benefit immensely by including people with lived experience, care providers, and advocates in the design of our studies to ensure that we capture the needs of the populations of interest. So I've heard many people in the care provider side saying that they're not sure if they can contribute. Please, we need you. Please come reach out to any of us. None of us will ignore you. Please reach out. We need you, and we need your opinions. And to our survivors, we need you, and we need your opinions in this research so that we can make sure that we are addressing the things that are impacting you the most. So with that, I say thank you. Thank you to the ENIGMA working group. And I think I left like 97 seconds for questions.
Thank you, Carrie. Carrie, do you see the question in the chat? Thank you for such an
Sorry,
informative.
I'm
Yeah.
just unscreen shared, so I can't. Thank you. Yes, we can put that the link to that video in chat. I will find it for you and put it in there for you. It
Thank you
was
so
developed, I will say it was developed in the US, but we tried to make it broad so that it could be, you know, useful across the board.
Thank you so much for that talk, Carrie.